Hi, I'm Brian Mandel, the editor-in-chief of the Cleveland Clinic Journal of Medicine, CCJM. Welcome to Beyond the Pages, CCJM podcast, where we will take you in depth into the content of selected articles from the Cleveland Clinic Journal of Medicine and explore a few interesting tangents along the way. Through moderated interviews with our authors and other experts in the field, we hope the clinicians will gain a more nuanced perspective of clinical concepts that are changing the practice of medicine and be able to apply this perspective to the care of our patients.
Welcome to the episode of Beyond the Pages, Contemporary Surgical and Procedural Management of Benign Prostatic Hyperplasia. We are going to dive in to everything you wanted to know about the procedural management of benign prostatic hyperplasia. And with me first, I'll talk about talking with Dr. Bradley Gill. Now, Dr. Bradley Gill, can you tell us a little bit about what got you interested in the field of urology?
Great question. So my background before medicine was engineering, and urology is the epicenter of technology in medicine. We have robots, we have lasers, we have implants, we have electrical stimulation, we have all the gizmos and gadgets that somebody could want. And a lot of them are used in treating BPH and prostatic disorders and men's health conditions. And that's really what my practice is. It's a comprehensive men's health practice. So a lot of BPH, erectile dysfunction, and things like that. And then beyond all that, working with my hands, surgery, and of course, humor. You can't have urology without having some jokes below the belt.
All right. Now, Dr. Ayodeji Shotimehin, can you tell us a little bit about your background? How did you get interested in urology?
Yeah, so I went to college at Emory and I went to med school in Hopkins, and Hopkins kind of has a pretty, big history in urology. But really what drew me to urology was, as Dr. Gill was kind of mentioning, is that we have access to all these different surgical approaches, right? So in urology, one day you can be doing a robotic surgery, then you're doing endoscopic work with kidney stones and lasers and like BPH with the TURP. And we're also doing open surgery, and we also have microscope, we're using a microscope in the fertility work. So that process of being able to kind of master all those different approaches throughout my career was really fascinating and kind of what drew me and attracted me to the field.
Thank you both so much. So we're going to dive into your article on procedural management of benign prostatic hyperplasia, but maybe we should kind of get out of the way, what exactly are we talking about? What is benign prostatic hyperplasia? And, how common is it?
Yeah, you mind if I take this one?
Absolutely.
Alrighty, so BPH, as you said, is benign prostatic hyperplasia. And I think to really get into it, I want to talk about the prostate first. What is a prostate? How can we visualize it? And I think the way to think about it is the prostate is sort of like a donut. Our urethra, which is a pipe, has to pass through, the donut of the prostate. And when we're young, that opening of the donut is very wide open. It's a big channel. We have no issues urinating. But as we get older, there are a number of cells within that, there's a special zone that's around the urethra that will increase the number. So the prostatic and stromal cells. And as the number increases, they create these nodules that essentially is going to begin to kind of close off that opening of the donut. So you think about a pipe, and the opening is becoming more narrow. And so that's what BPH is like if you think of it, kind of at a basic level. And it's really a condition that's going to affect all men. It's a condition of aging. So just depends on, when it's going to happen to you.
So it's okay. So this is kind of, you've had so many birthdays. This is going to happen. It's inevitable if you live long enough. So, thinking about that, as it's so common now and we have, these treatments we're going to get into, I feel like I like medical history, but I don't really hear about BPH historically. What did people do? What do we know about how people dealt with this? As if you said it's inevitable if you live long enough. Granted, people didn't live as long, not that long ago.
Yeah.
But what do we know? How do people deal with this?
I can talk a little bit about this. Essentially, once men started to live beyond the age of 50, BPH became a problem. It became an issue. And various civilizations found different ways to address it. So I learned that in ancient Egypt, for example, they would use Foley catheters made out of papyrus. That was their approach. In China, they'd use, the onion, I'm trying to think of green onions that have the hollowness. They actually use those as catheters to drain the bladder intermittently. So this is a problem that, once men can live past 50, it's been an issue. But I think kind of going back maybe 1700s or so, the mainstay of treatment was actually dorsal lithotomy, then found that they could get the prostate. And then that was when we started doing simple prostatectomy.
So what's the dorsal
So that was opening to get stone, cutting to get stone.
Oh, okay.
Yeah, it's like take care of kidney stones in the bladder stones. To take care of bladder stones are really problematic at the time. And then through that approach, they found that they could address the prostate and actually remove the prostate. Is that right?
In a way, yeah. So, I'll take Io's description of the donut here, and I'll one-up you with something healthier. I'll go for a watermelon. Okay. So I tell all my patients their prostate's a watermelon. The pink fruit in the middle is what gets bigger with age, and it closes up the channel that runs through. And a common misconception is that there's a separate urethral tube that runs through the center of the prostate. It's actually just an opening that's in the prostate. So that pink fruit grows, that channel, that opening kind of squeezes down. So our goal for prostate surgery is to get all the pink fruit out of there and open that passageway up as widely as we can and leave the white rind and the green skin of the watermelon behind. And that green skin is where the nerves are that do erections. So in a BPH procedure that's done appropriately, you should clean out the pink fruit. White rind, the green skin should stay behind, and a guy shouldn't have to worry about his erections changing with BPH treatment. The white rind of the prostate, so to speak, or the watermelon, is where prostate cancer generally forms. It's called the peripheral zone. So again, with treating BPH, we don't really think much about impacting a man's prostate cancer risk or things of that nature, but we are making the prostate smaller by treating that watermelon, getting rid of the pink fruit. And that should decrease their PSA too. So that actually, in a way, can improve PSA sensitivity, prostate cancer screening, and that's a whole other kind of rabbit hole we can go down for discussion.
PSA rabbit hole.
Yeah,
okay.
But the historically going back and looking, the early interventions, as Io mentioned, were using things for catheters. So Benjamin Franklin, for instance, was credited as developing one of the early intermittent catheters, which was a silver tube, a hollow, malleable silver tube that was used for intermittent catheterization. So procedurally, going forth, some of these stone surgeries were where they kind of noticed early on you could remove prostate. But if you go back and you look at the literature, there was a toss-up. It was March of 1889. There was a British Medical Journal article where they described the simple prostatectomy. So basically opening up and scooping out that pink fruit of the watermelon with your finger. And then that was described again in November 1889 in the Indian Medical Gazette. So these surgeries have been around for a very long time, which speaks to what we know about the prostate. It grows, it causes problems as we age. And if men did live long enough, they would have those problems.
So think about the people who didn't have access to these procedures, even in the late 19th century. What does it inevitably lead to obstruction and kidney failure, or sometimes it kind of stop, or what happens long term?
Yeah, generally speaking, the prostate will just continue to grow with age. And what likely happened back then, and you can piece out by reading between the lines in some of the literature, is folks died of urinary obstruction. They'd have bladder outlet obstruction, bilateral hydronephrosis, just eventual renal decline. The other way that they could run into trouble is if they form stones from urinary stasis. The bladder doesn't empty, things can deposit, they can settle, and you can wind up forming bladder stones and blocking the urethra or the outlet with that. The other thing that can happen is infection. So if bacteria find their way into an obstructed urinary system, then people can get really sick really fast. The modern day kind of equivalent there are folks that come in with an infected, obstructed kidney, for instance, passing a kidney stone. That's something that'll easily get a urologist out of bed in the middle of the night.
Yeah, and we even still see uremia now. I actually took care of a patient a few years ago who had undiagnosed BPH and eventually went to kidney failure and needed a transplant. And so it's something we still see now.
So let's talk about that. So you said the undiagnosed BPH. So what are kind of the classic symptoms? Can you kind of walk us through what a patient's kind of experiencing from the beginning, how it may progress, and then maybe your initial approach to workup?
Sure. So I'd say that the symptoms of BPH are likely gradual to the patient. We kind of divide them into two categories of symptoms. We overall we call it lower urinary tract symptoms, or LUTs. But you can have obstructive symptoms, you can have irritative symptoms. So irritative symptoms would be like urinary frequency. someone has to go to the bathroom every hour, every 2 hours, they can't hold it. Urgency, like developing a strong urgent desire to want to go. Some people even have burning with urination. On the flip side, with the obstructive symptoms, you'll have a slow stream, and it's usually a gradual process. You'll ask most men, they'll tell you, yeah, like I can't pee as well as when I was 18, but it's okay. So it's a gradual kind of slowing of the stream. You can also have getting up at night numerous times to pee. We call that nocturia, dribbling of urine, hesitancy, like where there's a delay. All those things are kind of classic BPH symptoms. In terms of the workup, we kind of start by like quantifying and those symptoms, like how bothersome is it to the patient. There's a number of questionnaires we can also give them. We can measure a PVR, so post-void residual, to see how much urine they're retaining when they urinate. And we can also do something called a uroflow, where we actually try to measure their maximal urinary flow. So those are kind of the basic things we do up front, and urinalysis just to make sure you don't have an infection.
Yeah, I look at the symptoms of BPH and, urinary symptoms in general, it's a little bit of a black box. So the patient comes in and they say, hey, I'm not peeing right, or I'm bothered by how I'm peeing. I'm frustrated with, what happens in the bathroom. And you ask them what's going on. They say, well, I'm going frequently, not much is coming out. I have to push, I have to strain. It's a big trouble. So then you really have to step back and look at the differential as to what the diagnosis can be. And BPH is everybody's first thought, right? So, your prostate's big, you're a little bit older, we just need to treat that. Here's your tamsulosin, here's your alpha blocker, you should get better in a couple days. But when that doesn't happen, then the question is, well, is it still the prostate? Is it really, really big? Or is it, maybe it's small and tight or shaped a way that's more obstructive? But then the other thing too is, what else could it be? Can it be glucosuria? Could there be undiagnosed diabetes? That'll give you small volume, frequent voids. Could it be constipation, right? The pelvis is fixed real estate. So if one side of that builds up a big stool ball, it's going to crush the bladder and the prostate anteriorly, upset them, prevent the bladder from filling, relaxing, cause a lot of those symptoms. So one thing that's really happened a lot in urology over the last few years is we've taken our focus off the prostate and looked more at just the health of the pelvic area in men in general. Voiding symptoms are very complex. A lot of different things go into that. And now especially being that we have iatrogenic glucosuria, right? So all of our folks on SGLT2 inhibitors, they come in and they're constantly dumping sugar in the urine. So they'll get referred over, hey, I think this patient has some BPH, go see the urologist. They come in and you look at the dip and there's 1,000 of glucose in the UA. Hands down, that's probably driving most of their urgency and frequency. Same with caffeine, coloring, sweeteners, flavorings, alcohol, all the things that upset the bladder. So outside of BPH, there's a lot of things that can cause quote unquote BPH symptoms.
Okay.
That's a very good point, because sleep apnea is another good one, right? With the nocturia.
Nocturia.
Yeah, sleep apnea is one that we see commonly as well.
Yeah, not many things will make a person urinate every hour, 45 minutes overnight, except sleep apnea.
Okay. That's good to know. So is there an approach to try and quantify the size of prostates for everybody when evaluating for BPH, or what do you do about that? Or is it kind of initial steps as medication once the diagnosis is made?
That's a great question. So if you look at the American Urological Association guidelines, everything now is stratified by prostate size. They're sort of small, medium, and large, if you will. And there's easily a dozen different treatments out there that we can do to help a guy that has an obstructive prostate, but those are all tailored based upon that prostate size. So in the olden days, our handy dandy cancer detectors, and those of you listening can't see my index finger sticking up right now, but the digital rectal exam was one way that we tried to quantify prostate size. And if you look at the studies that have compared that to imaging, whether it be ultrasound or MRI or CT, there's very poor correlation between the digital rectal exam and prostate size, and that's because you're only feeling the prostate in two dimensions. That third dimension, where the prostate grows or pushes into the bladder, you can't really assess. And a lot of guys that have big obstructive prostates have these huge median lobes that prolapse or fall into the bladder that you can't really pick up on a physical exam. So the other thing that has come with the guidelines as they've evolved is the use of imaging to size the prostate to help you stratify what treatment might be best for that patient for their specific situation.
Okay. So I imagine initially, their medications are initiated in these patients. So what percentage can we say this is the chance that this patient's going to respond to one of these medications versus having to go on to have some sort of intervention?
I can try to take this one. That's a very interesting question. I would say that most people typically will respond to medication as more of the side effects and kind of weighing the risk and benefits of that. But I'd say in general, most people respond either to Flomax or tamsulosin, which is our first-line agent, or finasteride, which works to shrink the prostate over time and takes about 36 months for you to see the effects. But I'm trying to think there. I don't want to talk about the absolute indications. Should I talk about that or?
No, we can get to that.
Yes, we can get to that. Yeah, I would say that most people have a good shot of responding to those first line meds, and we can give them. It's no harm in trying, and if they still don't have a good response, then we can talk about surgical options. But those are pretty. I think that works pretty well in general. Well.
Yeah. The to piggyback off that, medications I look at really as serving two purposes. One is therapeutic, but the other is diagnostic. So if a patient comes in, they have obstructive symptoms, they're bothered by their urinary status, we can try an alpha blocker. You can also try a 5-alpha reductase inhibitor. Daily tadalafil is another great option. Relatively fast acting, similar to your alpha blockers like tamsulosin or silodosin, so forth and so on. If a patient comes back and they notice an improvement in flow, if their emptying's better by post-void residual, if their symptoms are improved on medication, then that tells you, hey, there's probably something going on here with either the prostate or the bladder neck that's obstructive. So the bladder neck's the other kind of player in the equation here, especially in small prostates. It's this big, I'll go back to Io's donut here. It's this big donut of muscle where the bladder and the prostate join up, and it's very rich in alpha receptors. So that's another place where you see those medications really have effect, is a smaller prostate with a tighter bladder neck. Those folks can respond very nicely to alpha blockade. So if a guy comes in, responds, does well on medical therapy, but says, hey, I don't want to have to take this pill every day the rest of my life, what can I do? Well, you've already shown us that you've gotten better with treatment for BPH. You likely have BPH. If we don't have prostate size, shape, those kind of things, then we'd usually talk about going on to the diagnostic evaluation, which varies a little bit by practice, but generally involves some type of sizing, transrectal ultrasound if you're in the office, CT scan, low dose, no contrast, or a prostate MRI, which we have a lot of nowadays if men are being worked up for elevated PSA, prostate cancer, things of that nature. And then the other part of the workup is generally cystoscopy. And that endoscopic evaluation is particularly helpful if you think that there might be something else going on, somebody that's had prior instrumentation, maybe there's a stricture, prior urologic surgeries like stones, lots of catheters, things like that. Or if you're considering some of the newer treatments that are really dependent upon the prostate configuration, so the shape of the prostate. You go in with your cystoscope and you can see, is there a median lobe? Is there a high bladder neck, a high median bar? Or is it just old-fashioned, plain vanilla, giant prostate, falling in, closing things up? Because the treatment that you'd pursue will really differ based upon that shape and size.
This concludes part 1 of this episode. Please join us for part 2 as our conversation continues beyond the pages.
Thank you for your insights in helping us to go beyond the pages of the Cleveland Clinic Journal of Medicine. To read CCJM articles, visit ccjm.org. To participate in other accredited educational activities, visit ccfcme.org. You can subscribe to the podcast on Google Play, Spotify, or however you prefer to access your podcasts.